Welcome, everybody. We're really, do people want to move forward, or is everyone comfortable over there? Just because there's like this empty spot in front.
It's not a good way to receive your
It's got that awk aspect to it from the front angle.
Just don't do things that way in my country.
So we're really thrilled to have with us today Dr. Subhash Chandir, who is an epidemiologist, lecturer in global health and social medicine, works with us at our Dubai Center. And so many get to see him, even though he's been at HMS for a while, because he is in our other location. He's a maternal and child health at Active Research and Development, which is a social justice NGO that I think works in 15 countries now. So he received his medical degree from Pakistan and his master's in public health and doctorate in global disease epidemiology and control from Johns Hopkins University, which I believe is also in Pakistan. For the last 14 years, Subhash has conducted and participated in various studies and projects in Pakistan, Bangladesh, India, Kenya, Nigeria, Peru, Ecuador, the US, and the UAE. And he's focused on maternal and child health research and service delivery. He teaches infectious disease epidemiology, vaccine-preventable diseases, mHealth, about economic incentives, patient survey methodology, and force empowerment. He's also a research affiliate at MIT and associate faculty at the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. And so we're thrilled to have Subhash here today to talk to us about some of his work over the last few years on maternal and child health. Subhash, welcome.
Thank you, Salman, and good afternoon, everybody. So I'll be talking about different people power as to vaccine coverage. And as Salman mentioned, I work in the department, and I also work as Director of Maternal and Child Health at IRD. Some of our today is a collaborative work between the two places, while the rest of it is essentially based at IRD. For those of you about IRD, it's an international not-for-profit organization working in 17 countries, with offices in 7 countries. We have a child health program, infectious diseases program, negative tropical diseases, non-communicable diseases, and global surgery program. So as interest, so I'll just skip this. To give you a slide, basically shows different projects and programs that come under maternal and child health program that I lead at IRD. I'll give you names of all these different things, and then I'll focus on a few of them. Start with, we have Zindagi Mahfouz, a digital immunization registry, which is one of our flagship programs. And more about that. We have incentives and reminders to in demand generation. We have SM-based GIS tracking, something that was actually Gavi Innovation Award last year. We have antenatal care program, under which we have AFC reminders, we have teeth screening and mental health in pregnant women. We have predictive analytics to profile lines using artificial intelligence and machine learning to improve the compliance of different programs. Then we have management of childhood illnesses, OpenSP, a digital player for integrated RMNCH. We just a reminder study. A lot of studies assigning immunizations are focused at the individual level, trying this coverage and so on. And very studies are actually based at the community level, trying to utilize that power to raise coverage. We have some of that work too. Then we provision in family planning. I'm also working with Johns Hopkins on a study trying to various survey methodologies for the immunization coverage. We evaluate mass immunization campaigns for polio and measles. We are also in cold chain monitoring and like real-time solutions for that. Then we have an advocacy program called Karan Sitaras, where we have potential of school-going girls is awareness as well as identify under and never children, and then we have screening and treatment. What essentially is what the work that has been funded. This is all funded work. There's a lot more that I do essentially under this program, which I bring in my kitchen, the interventions that essentially are promising. We bring them to the studies and eventually into the programs. So what is this program essentially? It's not just a research program where we just keep research, finding evidence and so on. But what we do essentially, half of it is research, where we try new ideas, innovative ways, maternal and child health. Then essentially, once proven, we integrate them into the programs at district levels, and then with the governments to scale them up.
So the provider is the Ministry of Health programs?
Yes, we feed into that eventually. That's the major point. Global footprint, a lot of work is in Pakistan predominantly, because after I finished my PhD, I moved to Pakistan for a few years. So a lot of work is based here. And, we're also working in Bangladesh, Indonesia, and Nigeria, expanding into South Africa and Vietnam. Within Pakistan, we work in various cities, the different studies and projects going on. In the PropSyn, we have a lot of work, and we are working with a scale 2 programs at the provincial level. Back to the problem. All of us have heard that immunizations are improving globally, more and more coverages and so on. But here's the slide. This basically, the color of the circles, they show you the coverage, the DDP3 coverage. Red is the lowest, and as you move on, orange and show around 70 to 90%, and then green is 90 to 100%. The size of the circles, basically, they show you the numbers in millions, children who are under-immunized. At least the largest number of kids under-immunized globally are in Nigeria, Pakistan, Indonesia, and Philippines. So overall, how good the picture looks like, that immunization coverage rates are improving. We have huge pockets. We have countries with large kids in millions who are not immunized. Pakistan, again, overall, it shows a better picture that we have coverage around 30 to 50%, but you see the variation between different provinces. The Sindh province, where we have a lot of work going on, is like only 29%. Then we have Balochistan with 16, Punjab with 66, and with 47. So a lot of variability in the country as well, and that applies to all the developing countries and elsewhere. So even that could be good. They could show that there's a good picture, but once you go down and you look at different variability, you would find a huge difference in the coverage rates. Only 1 out of 5 children are under-immunized, while in Pakistan it's actually 3 out of 5 children that are under-immunized. So that's what we are dealing with in Pakistan. Back into the histories, conducted a study on the forms are conditional gas transfers and improving DDP3 coverage. Now, a lot of have heard about the large conditional gas transfer programs in South America, including like in the US, for example, we have women and infant and child WIC program, and then in the developed countries with incentives, positive or healthy behaviors. But they're among in the denominations of $40, $50 and above. What there's evidence that CCTs work, but what can be effective in the duration of like $1 to $2 or even smaller thing, something that is less than $10. So basically, the DDP3 coverage between control, which is the blue, and tension curve, which is red. As you can see, there was more than 2-fold increase in the DDP3 coverage rate by giving an incentive of $2. That's the receipt for coming in for the timely immunizations. So we were that CCTs are actually working. When we took these things to the government, they were like, okay, we understand CCTs work. Government doesn't have enough money. Developing country governments don't have enough money. Pakistan government said they didn't have enough money to give it to the entire birth cohort of Pakistan. Around a million things. They were like, what could be done essentially? Basically, we wrote another protocol, and we got funded in 2011 by UN Foundation Innovation Working Group to pilot basically industry whose goal is to increase immunization coverage and timeliness using technology and economics and generate real-time actionable data. I like the word timeliness here. Countries, they focus on improving coverage. The example of Bangladesh, their coverage is essentially 85 plus. Immunization coverage, national immunization coverage is 85 plus. However, they have serious challenges with the timeliness. So a lot of countries, they first try to achieve coverage and then work towards achieving that timeliness. Which is that if a child is due for vaccine at 6 weeks, he should be vaccinated at 6 weeks and not at 6 months. What we try to do, essentially, we try to address both coverage and timeliness at the same time. So we spend next 10 years working on doing coverage and then spend another 10 on the timeliness. Yes.
One question. Are you aware of any study that has not shown that it will improve or increase utilization? I mean,
Yes, there is mixed evidence there, for example, from South America, in the progress, and for different interventions, not just for immunizations overall. There's mixed evidence saying CCTs don't work, and there is certain evidence, like, for immunizations, for example, there's evidence that they have worked. So yes, there is mixed evidence, and the more work needs to be done.
Well, I know a little bit about the South America data, which is easy to pick apart. In other words, the inconvenience of obtaining the incentive, obviously the incentive, and yet the debates about barriers and user fees continue as if there were evidence to support maintaining barriers and user fees. So that's decade after decade,
It has been challenging. With part of it as well, but ours is different because we are looking at the small incentives. When we are saying like we only give away $1 to $2 or maximum like $5 sort of denomination, as compared to saying we're giving 50 and 100, and the issues that come with it.
So you're basically saying, look, don't get us too hard. They're only tiny amounts of money. Don't bother us.
Yes, but I'm saying more to it. It's like, what is the cost of not doing it? Like, what interventions do we have to address the challenge that we are facing? Like, which is like 20 to 40% to raise it to 95%. Like, when countries procure vaccines, they pay for the entire birth cohort. They don't calculate saying, oh, we will only immunize 40% of the children, so we should only procure 40% vaccines. There are vaccines for 100% of the birth cohort. In the end, those vaccines get expired. Cost of that vaccine, if you give a fraction of that,
yeah, I know. I mean, I'm saying the
economic benefits outweigh it.
No, but I'm saying the economics are so obvious that I'm asking, why do you and we and lots of people have to keep on saying the same thing again and again? That it costs a lot to not do this, and they're just minor differences.
Sensitivity around saying that you are giving away money.
Yeah, it's way back.
Yeah.
Right? And what Salman's book is about.
So I'll speak a bit more about your segment. Not be completely answering your question, but then some of it, we'll try to engage the global payers in incentives and what was the response and what are we doing about it. So I'll show a clip of that. So back to the fight we did in 2011, it had 4 interventions, and I would say there's an intervention that would bring us from 40% coverage to 95% coverage. It has a combination. This is a package of interventions saying, okay, we will address supply factors, we'll address demand side factors, then multi-pronged approach that would lead to the optimum coverage level. So we have frequency ID cards, RFID, we have and response stickers for the EPF identifiers. So one of the changes we have is it's hard to uniquely identify the children. Immunizers, they issue the rank numbers which are same across the center. So if a child moves from one center to another center, you can't locate the history, immunization history, or the record of it because the same number. There are multiple children having the same number. So we use radio frequency ID, RFIDs, back on 11. Continued that and shifted to the quick response code because RFID was costing 20 cents per piece. I mean, it's costly in terms of the economics of it. And quick response codes, you could actually print 45 of them on an A4 size printer. Convenient and could be printed anywhere. The other intervention we had was electronic vaccine registry with both web dashboard, plus code-based entry and access. The third we had was a lottery-based conditional cash transfers. So what essentially, we understand that government cannot give CCTs to everybody. The conventional CCTs, the way things went on the CCTs. We want to do lottery-based CCTs. So rather than giving incentive to everybody who comes in for the immunization, how about we give it to 1 out of 5 or 1 out of 10 people?
Non-starter to have a redistributed program in Pakistan. I'm just
so when we did that, we had these 4 interventions. So
no, I get that, but I'm saying you said not possible for the government to do CCTs.
Yes.
So how do we know that? I mean, who says no? The Ministry
of Finance said no. Yes, no. It never been the Ministry of Finance. So by using the Minister of Health, the Secretary of Health, the EP program, and all other relevant people, like the Secretary for Public Health, we had discussions. We engaged everybody, but they were like They are not paying for the CCT program. They just can't afford it. Response that we received from the government. That's why we okay, how about we do the lottery-based program? They're saying don't pay, you don't have enough money, you can't pay, all the, let's say 10 kids or 5 kids, pay 1 out of 5 and see if even that yields the same results. So that intervention we introduced. And the fourth one was interactive reminders are two-way SMS. So we have heard that SMS, reminders work to improve compliance. It has worked in different settings. The way essentially, so it's not only it sends the reminders for the appointments, but actually respond back and engage with the health center. And I'll talk more about that. So these 4 interventions: radio frequency ID, based education, electronic vaccine registry, lottery-based cash transfers, and two-way SMS. As you can see on the phone, they quickly simply just scan the QR code and the nursing history of the child pops up, and again, it's also stored into the web dashboard. SMS, a total of 3 SMS was sent. One was sent actually one before the due date. The second reminder was sent immunization in the morning, and the third reminder a week after, only the child did not show up. These were customized essentially. So they would take the child and tell them that they are due the immunizations. And when we were setting up this pilot, we actually did focus groups with the parents trying to find out how do they use SMS, what sort of language and the characters they use. So essentially we ended up with Roman Urdu, which is like local language, but written using the English characters. That was widely used and everybody understood it. So that's Roman Urdu that you could see here. You can read it, basically says that your kids should be immunized, and it names the child as well. When we designed this, we were not thinking of any other benefits. We just engage parents, and what out of this, parents started sharing their concerns and queries like Sadik, how long is the due date? So you got complaints, like we went to the center, they were out of the pentavalent vaccine. They also information saying we have lost the card, can we get another one? Just responding to these simple messages, we actually prevented under-immunized child at each of these instances. Required was simple, few seconds response to these messages. Now, interestingly, furthermore, parents also started sharing the adverse event data. Adverse event data that we have for the vaccines comes from developed countries. The limited data that comes from the developing is really hard to do that. We actually, showed the evidence that parents were actually telling us that Zain has developed a rash. What should we do? A child developed high-grade fever. We went to the doctor. They were even naming the antibiotics that were prescribed by the doctor as well. So all adverse events data, that was coming in. Then there were also vital events that were being reported by it, like Sadia has died. Initially, when we set this up, this data sitting in the registry, but now working actually with the governments so that this data, for example, could feed into national vital statistics registry, and all this data goes in the national database. Now, designing the amount of the small conditional cash transfer wasn't easy because there's not much evidence on it. Very little has been done on the small amount CCTs. So on days of deliberations, we were like, okay, we know for the immunization, that's the first visit in the recommended immunization schedule, there's coverage. Measles too, essentially, it's 20% coverage. So we are basing for BCG, where it's 80% coverage, we'll give $2 incentive. For the which has essentially 20% coverage, we give $8 incentive, and then similarly 2, 3, 5, 6, 7, and 8 for each of the immunization visits. That's how we set up this schedule. That's the logic that was behind it. There was no evidence to help us design, to give us a start. Interestingly, so at that point in time, it was remember in 2011, there were no wires, no smartphones at all. They used to be just phones. So there was people are not tech savvy as they are in today's world. When we went to the government, they were like, so you're saying the data would be stored on the clouds. What if the clouds vanish? What if the data is gone? And those sort of things. So we actually to convince them, okay, it's not like that. Then it will allow you to have pilots, but vendors will use both paper registers as well as the phone-based data entry. That is a challenge essentially. Vaccinators are already overburdened. Asking to do more work where you fill the paper registry as well as the phone was a challenge. So we stipend of $60 for every vaccinator, saying that, okay, do this work, you're actually immunizing kids using the register as well as the phone, plus $60 stipend. This program, we realized we are not going to get anywhere because the enrollment was too low. At that time, we said we will actually tie the purpose of the vaccinator with income. Rather than giving a flat stipend, we said every time a business, basically, they also get a portion of it. So they get like 80 cents for BCG, Penta 1 and Penta 2, and $1 for Penta 3, and similarly 1.2, 1.5 for measles 1 and 2. So that was an incentive. So more immunize, more actually once I was in one of the town health offices and I saw vaccinators fight. He was being transferred by the town officer to a facility, and the vet was fighting, saying, "I want to stay at the Zindagi Mahfouz vaccination center." I was just wondering, you actually have to work at the center, because if you don't, your performance is shown, in a real-time thing. But if fight to stay at the Zindagi center and not go to a different center where they don't work actually. And then we analyzed what actually, I was just thinking if we are paying too much to the vaccinators or something which is not right. So actually, salary of a vaccinator is $160.
Well, that's way too much. He knows I'm joking.
Monthly performance-based incentive, essentially, the average incentive that we're giving out was $65.
Now,
So just about, we flat a stipend of $60. They didn't prove anything. They were just doing whatever they were doing even before the program. But tied to the performance, it really changed everything. The first amount was still 65, so like $5 more than the month that we were giving the flat stipend. So from it came up to the 65, but it was much. 65, and that changed everything. I'll show you what happened. And the mode of transfer was money transfer. What is integration and work hours? Same vendor who used to come like for 2 to 3 hours a day and 2 to 3 days a week, now coming up at 9 a.m. and stayed up till 3 p.m. for like 6 days a week. Clients. Previously, they didn't bother whether or not the mothers and parents bring their kids or not, but now they would greet them properly. They would tell them more about immunizations. They would do their counseling so that parents would come back. Everybody knows in Pakistan and in a few other countries I've seen, but it talks about it is there's unofficial fees that they charge. Even though immunizations are supposed to be free, they charge you 40 cents per visit. Nobody talks, but everybody knows that this is a practice that happens. They stopped. Vaccinators, this was a very pragmatic program, and all the interventions were pragmatic. We didn't do anything. We didn't ask you to change your practices, so what made you stop? Why are you taking this fees? And they were like, we only take it when our wages are low, so this is like sort of an additional income. But this additional like incentives to the program, that solves our problem. We don't need to get more money from the parents. We don't need to extort more money from the clients. And then the availability of routine EPS services, so they were recognized for the improved vaccination performance at those centers. So the government has really struggled all those years saying how to improve, how to make these vaccinators work, and they have failed. This thing changed. With these results to the government, what the first response by the program and the health secretary was, seriously, you are telling us $65 is making this change, let's just increase the salary of all the vaccinators by $65. And that's not going to change anything at all. Changing their salaries is not going to work. It's basically performance-based incentives that is changing it. The kick that essentially they have to perform to get this additional incentive is just making it work. Just by the salary will not do the trick. The pilot. The first here is that's the demographic health survey results, and then the darker blue is essentially the registry results. The program was set up, as I said, it was a feasibility pilot, so we didn't have any pre-post designs or any other control arms. It was more towards just programming whether or not this program could actually work, feasibility side, and then we compared it around the demographic health survey that was done around the same time when it was being done. So the Penta 1 was 65% coverage in Penta 1 compared to 84% in the registry. Same goes 57 for Penta 2 versus 4 in the registry. And fully immunized child, you would see is 29%. In the it was 54% in the registry. So the way system was working essentially, it has a very high retention rates, and all the kids that were actually enrolled in the system, they're highly likely to complete all the immunizations. The program from June 2012 at 2 centers in Korangi, Karachi, which had 15 vaccinators, enrolled more than 27,000 kids over the period of 2 years. And as I mentioned, the fully immunized child coverage raised from 20% to 54%. So what did we find essentially? Seeing that, okay, there were successful interventions which had lottery-based CCTs, and, left registry, made a difference. The two parts, the digital part, there's a registry, and the second is the conditional cash transfer. So I went to the Gavi, I had a meeting with different stakeholders, including, with Dr. Sid, that he was the CEO of Gavi, but like, okay, these are the findings. We showed him. He was wonderful. This is working. Now, for me to take this on and scale it in 70 countries, they were like more. So we understand small incentives are working. We could, Gavi could put the support behind the incentives and actually implement it in the Gavi supported countries. But they would evidence, they wanted to know how small the small need to be. So $2, but like, he was like, what is small for the small thing? They could actually support it across the 70 countries.
So the government is saying how small it's going to be. Government is saying how small.
Government is saying they can't support a CCT because it's too much money. Getting evidence works.
I want to
because it's effective.
I'm going to give you a in a minute.
The small incentive should be. And then the schedule of it. The schedule of it saying, and the design essentially. So you give the bonus incentive at the end. Should it be lottery or non-lottery? And different variations. So we said, okay, I will back to Gavi with these things. What then I did, essentially, we have a randomized control trial in which we are evaluating the impact of small incentives on immunizations and relative effectiveness and cost effectiveness of a range of different schemes. And I'm going to show you in a minute. It's fun like Global Innovation Fund. Now, it's an RCT that we have started. What it basically, it compares, low incentive with the high incentive, and even the high incentive, these are all small amounts. If you could see in the end, the incentive essentially is like $15 total. This high incentive is not touching the $40, $50 amount that we see in the large CCTs. And then there's the flat rate or the shop rate increase across visits. It comes lottery versus not lottery, and actually bonus amounts. And then what we're doing, the challenges that we have essentially is to make like these incentives with of challenges going on around with it. So what we initially said that we will be giving the conditional cash transfers and realizing the challenges that we are having. So we actually changed the design and made all these different, like 9 to 12 arms basically would be using mobile top-ups, transferring the mobile balance rather than the cash. The 10 is doing the cash transfer, which is Easy Pesa, and then there's a SMS arm and the control arm. We will have around 11,200 cases, just 3 years to get the evidence, but we'll have our interim findings and everything to share to keep pushing that this is something that could be worked. Now, that's where we actually took the incentives part. Now, coming back to the registry part, that's the other thing, for example, that is a game changer. And I think with the, as I mentioned, Java phones are like, flip phones, Nokia, but we have obviously now the Android phones, works on the smartphones, that cost us like, $40 a piece, and so on. And the features that come with it. And today, the registry offers is like web interface, which already had, I mentioned. Then mobile entry and access, QR-based identification, directive reminders, offline basically. So we have these issues where there's no connectivity. Sometimes for security reasons, government shuts down the networks for days. In the actually offline mode would work. It's not like, you have to search back to the papers or something. And then registry. One of the things that we have, countries, vaccinators don't even know how many kits exist out there. So that's what, I've seen when I've gone to these meetings, sometimes what should I, whether I should go with the flow or just hold back. They look at performance of all the different teams, vaccinators, like, vaccinator teams in the district, and say, oh, I had 80% coverage. And he's like, insulted in front of everybody that he hit the target, and he's getting back that he like immunized 80 out of 100 kids because his target was more and he only got 80%. This guy says, oh, I had 120% coverage, and everybody gives him a standing ovation. Know about it, like 20%. How could you have 120% coverage when essentially, going, so this is wrong with the denominator there. So basically saying, hey, when you go and you have 100 kids in your area, immunize them. And then 20 kids go and immunize them. They don't even know the actual target. We have household registry. Basically, what we try to do is through vectors and the government staff that does the household visits, these are the children. So there's some idea of what is the actual number of target children, rather than, and just to give you more idea, they are based on 1998 census, 30 years old census. Just think about a really tough situation out there. We are doing essentially with the registry, as I said, trying simple things. Just by designing the registry, all these things are very easy to do now. Built-in decision support system. Ask a vaccinator what is the schedule, or what would you do with a child who comes in at 6, 10, and 14 weeks, and at 9 months, they'll tell you, like literally, there's these are the vaccines I would give. But what will you do with a kid that comes at 6 months? They'll be lost. And there's the missed opportunities. A child will be getting 3 shots, would only get 1 shot because of the vaccine that couldn't figure it out. And that's true for the developing countries. I took my daughter to the Johns Hopkins Children's Hospital. It was flat. The pediatrician there messed up the schedule. Affects both developing and developed countries alike. What we did essentially, we with them so that vaccinators don't have to worry about it. All they have to do is simply scan the child's ID, and then the education guides. So green color basically shows the child is vaccinated. Gray, you don't need to worry about it. Red color is basically the child is overdue. So now the outreach arm, they should actually actively reach out for these children who are 4 weeks past the due date. So there's a color. They don't even have to put too much emphasis on their brain trying to figure out what is the schedule or what needs to be done. So green, done, is really, basically there's a darker blue which saying the child is due, it just means it's overdue, go after it. Then gas tracking. The thing is we have virtual immunization certificates. So long-standing policy that at the school admission, they would verify the immunization records. Nobody does, but according to the current comprehensive plan, Pakistan decided that they implemented by the end of 2018, all the schools would emphasize on collecting the immunization history data. So, okay, and around what happens, basically, you could go to any or some other store, give them 50 cents, they would make you a fake certificate. What does you send SMS to the server SMS-based certificate. So usually how many immunizations were done correctly. In case of records, you don't need to like hold on to the record. I mean, there's cards, which the card retention is really low. It's like less than 20% by the age of 2 years in developing countries. So all those issues are addressed. And the defaulter list for the convenience, and there's micro-planning and so on. So all features actually, out of the registry as of today. I'll tell you a bit more about that. And then features that are in the R&D essentially, that is analytics, which is using machine learning and artificial intelligence to predict what will happen to the child. I'll talk more about it in a bit. And then adverse event analysis and treatment. It's more on the research side, saying with the trials where we could collect more data on these factors. What we did basically, in the 5 years, we had 155,000 kids. All those like overall FIC was improved, better vaccinator performance. So it addressed both supply side and demand side issues, making the program basically there's a lot of uplift, so it actually works. Early in the month in the Sindh province in Pakistan, so essentially all 500 vaccinators in the state, 500 workers who are who also do the immunizations, 600 centers across the state, 29 cities, and 2.8 million children in 2 years were immunized through this program. So definitely we started based on 11, slowly piloted, we did district-wide coverages, and eventually with the support of the WHO and other partners, we have finally scaled it up at the state level. This is a map of the Sindh province. Throughout this time, we have been engaging government and all the stakeholders. As I mentioned, right one, when we ran a research project, I never got saying that, okay, we'll just do it for the sake of research. From day one, think how sure that the results are positive, they become sustainable. So just to involve all the stakeholders from day one and keep moving and keep expanding in country and elsewhere as well. So we are in Pakistan now. The same registry essentially under the Open SRP is being implemented in Pakistan, Bangladesh and Indonesia, and it has been used by MFS in the Central African Republic for the mass polio immunizations as well.
Sorry, so exciting.
Predictive analytics. So different, like government says they don't have money to do it. They support X, Y, Z intervention. And then I was, how about if actually help by the children who are the follow-up immunization? And this child will show up and this child will not. On the likelihoods and probabilities essentially. So to improve routine immunization and timeliness program, there's 80%, 80 plus BCG coverage rate, which is really high, and the line is measles, the dropout is huge.
So, that vaccine and low for.
No, I would say, like, when you are starting, so you are saying you are capturing 80% of the children at the start of the program, but by the time of the program, you only end up with 20% of the kids. So we were like identify variables correlating with the higher risk dropout and then improved immunization equity. A bigger challenge in development is saying parents are actually more likely to bring the male children to the clinics as opposed to the female cells. That's the other gender thing that we are struggling with. So using the machine learning and artificial intelligence, the sum actually profile identify the children who had high risk of defaulting at follow-up immunization, and then the second is basically the low risk. And the whole logic is, if you can identify the higher risk, so if you have limited resources, how about just target those limited resources to the only high risk? What is, whether it's conditional cash transfers, SMS reminders, or whatever the intervention that government believes can work, rather than on the entire birth cohort, let's just focus on the people who are likely to drop out. And again, for the pilot of the artificial intelligence thing, we actually used different models, including vector partitioning, support vaccines, random forests, and conditional industries. Because we like, yes, let's use all the 4 public models and the artificial intelligence, and then let the system do within that. So not only, so what does the system do? It runs all the 4 models simultaneously, and then which model is a perfect fit, and then use that to actually predict the likelihood. So I'm using one model for the artificial intelligence. 44,000 kids, 44,493 kids, pilot study from the 21 immunization centers in 2 cities in Pakistan. So it broke the 44,000 kids into 2 cohorts. One was the training, another was the validation. So the training was used to train on all of these different models that we use initially. It's all routine collected data. So it's not a research project saying we'll collect any data just, to see what will work. Like address, date of birth, age group of child, enrollment vaccine in stock, enrollment vaccine timeless, and the gender, child, and language. Synthetic variables to predict what will happen to the child for the follow-up with it. Now, you use 4 models. You see the curves and the C statistic. Assign all the, that we saw was the 73% with the forest, while the highest C setting we had for the C forest, which had 81% prediction rate. Start. So let's just say after deploying it for 1 year, because it's an artificial intelligence system would self-learn and keep improving. By the end of 1 year, it will give you 99% accuracy whether or not the child would come. So it has the potential to improve timeliness, average, improve and financial performance, leads to efficient targeting of limited sources, and then obviously achieve health equity. And more importantly, I'm also engaging the groups, for the TB and diabetes management, saying this could work for the immunizations. Now we need to use it for the other domain areas and see if it can help, for example, improve the patient compliance for the TB and the diabetes as well. Solutions. So all of you use your, I guess most of you use your maps for going to different places, right? On your smartphones, and it drains the battery essentially. If you leave it on, your cell phone battery would be on in less than 2 hours completely. Now, people use GIS tracking, and I was like, okay, what should we do in countries where not everybody has a smartphone, even the majority of them has, but not everybody, and then the battery which is killing us. So we actually said, okay, well, how about we use the GSM tracking? Now, GSM tracking is used in the past to track the locomotives, the trains, basically, where they have regions. So it's a very cheap method. And so what again it was track mobile phone SIMs, the GSM-based tracking, tracking an online mapping service. So basically, it's called poor man's GPS because it doesn't need a smartphone, doesn't need all those things. It relies on the cell phone tower triangulation. You need at least 3 towers to know where the SIM is. And again, the high penetration of mobile phones. The smartphones, but just saying everybody has a phone. They have it. And so this phone tracks the SIM, nothing else. You don't need to have GPS in your phone or anything else. It's simply the system tracks the SIM. Accuracy is 50 meters as opposed to 10 meters with your, with your GIS, the GPS-based GIS tracking. all you need to run this, to deploy this anywhere, is 25 cents per month. And 25 cents, and you could track one person for the whole month. What did he or she do? And all phone numbers. Let's say today we decide we want to scale it up in this part. Just get the cell phone numbers and put them on the track. It comes with features like geofencing, team view, route view, active surveillance. There are systems where you have to get on the system and see, okay, who the work or not, whether the vaccinator went to certain village, certain town to do the activities. You could do basically, you could set up the targets. This person not go to a certain village. The system would send a message or an email to supervisor and the program office. So the very system following up the people, very efficient supervisory system. Results at different points in time to see, like, and this was interesting when we deployed it initially. People did not know that, they knew they were tracked, but they did not understand how this works. So when I called them, the district office, or where are you right now, the person was like, outside the district. I'm actually, supervising this particular center, and we are saying, you are not here. And there's a moment that, and the commissioner was calling himself because he was also excited that he got this tracking system in his district under the pilot program. He was seeing this guy who was on the way to Karachi, like literally 6 hours outside the district, and he was telling the commissioner, "Oh, I'm in the city and I'm doing the polio surveillance right now." What happened? Until they realized that they are being actually watched, they are being monitored, and it started changing. We tracked 20 workers for 5-day campaigns in 2 different districts. They started, there were absentees, and then obviously it highlighted the best areas for the absent targeting. And this flip, as I said, is very cost efficient. And then this is the same thing which actually won the Gavi Innovation Award last year, and we have received funding. Actually, this month, the contract is finalized, where we are scaling it up in the entire province in Pakistan. We have MCI, and then obviously MCI covers a lot of different things. I'm not showing the data on diarrhea, pneumonia, tuberculosis, and other things that we do on MCI. But for immunization purposes, 44,000 children were basically screened under the IMCI, electronic version of IMCI program. There was 28 kids never vaccinated, the mean of 7.2 months. So we are saying the program was identified 17% children who were never immunized. And they're essentially basically 18 days to 2 years old children. A 2-year child never immunized. And also around 30% of the kids who are under-vaccinated. That's somewhat. Now, to give you some idea, IMCI is basically, again, comprehensively, screening the child for all these different diseases. It's a very complex module that has not been able to, even though, it is backed by UNICEF and WHO, and a lot of countries have signed the petition and they do it, but actually not implemented. The elect version basically simplified it, so they don't have to flip around 60-page book trying to find out what the next question be in the algorithm. The system does it for them. So this is what we're doing essentially. When you go to a different country, you would see WHO would give you a different estimate, UNICEF give you a different estimate, or whatever survey would happen, demographic health survey would give you a different estimate. So we're like, in the presence of all these different methodologies, different surveys, how to best actually gauge or estimate the coverage rate. Community tools, again, we will also show you a glimpse of different community engagements. For example, we have these videos as well. The social media. So then our advocacy program, the Kiran Sitaras, where essentially we have engaged school going girls like 9 and 10 grade, go out and identify children. Like initially when this concept was, nobody was like, even I was questioning, can I actually engage 9 and 10 grade students, the girls basically, to help identify children? But then what comes to me was like, 200 numbers were brought back to schools and 335 child marriages were stopped or delayed by the Kiran Sitara. If a 9 to 10-year-old, 10 grade girl can start child marriage, like they could definitely help with the immunizations as well. So we did a quick pilot with 57 girls. The primary outcome was to identify the number of both never and unvaccinated children. And as you see, at the 3-month pilot, the basically blue bar is essentially for the household survey that we validated, and then like the green bar is basically the number of kids identified by the Kiran Sitara. So I had 7 never vaccinated children. Total size is 135 children that they reported. While validation, we found only 2% of them were vaccinated. But they are identified 7% while they were 19%. What they are saying, the way we are interpreting it, that's doable. We offer modules to train the 9th and 10th grade students to identify under and never immunized children, and they could actually help us identify and fill the gap. And the other part is like when these girls grow now to be women, they could actually be advocates for lifelong, saying that their circles, their communities around them, the people around them, they would be convincing to bring their children for the immunizations as well. So it has short-term and long-term benefits as well. And in social influences study, talking about it's easy for people to do the individual level studies, but talking about at a community level, engaging parents and seeing what benefits and then drawbacks of not immunizing your children, what happens. Bracelet study, a simple silicone bracelet, whether or not that could actually help them reach the coverage. A simple silicone bracelet is essentially we tell the parents that they're seeing this essentially. So every day they come in, they punch the moon, and their kid has to reach the star to be fully immunized. So that's they try to work. This is for the illiterate women. ANC, we do different things. There's a digital, as I mentioned, OpenSRP, a digital platform for the RMNCH, and SMS reminders, free of cost medications, TB and treatment, and mental health screening and counseling. When we started the mental health projects, we enrolled 20,000 fees for the ANC program, where they were getting the reminders and so on. We have screened around 92,000 women for the tuberculosis. As a pilot, 800 women were screened for the mental health challenges. Prevalence of unusual depression. 16% women who are identified to be depressed during the first trimester, 21% in the second, and 24% in the third. So 23% had depression even through the pregnancy. That's what we saw, in our pilot program. This is in the screening, pregnant women, ANC, and then postnatal cooking as well for the tuberculosis. What we identify, there are around 1% tuberculosis positive rate, but most of it is based on the verbal screening. I'm working with Mercy and other people to algorithm that works to identify TB. And we receive funding for all these different works from WHO and all sort of different things. Then banks like Habib Bank, Pakistan, and different international donors, and then the partners of the world. Thank you.
Thank you for that. So there's some time for questions. Meredith, did you have your hand up? You were just okay.
You were asking something. I'm sorry, I didn't.
Thinking about the privacy concerns and the ethical issues with tracking people and
Sorry.
privacy concerns and the
That is the other ethical domain that is yet to be fully explored, like seeing people seeking permission that we will track you. Like it's okay till 5 p.m., but the challenges are after the
drones.
Yes, I mean yes. Again, the same thing. Like how do you come around the ethical
Sky's
concern
the
of
limit for that.
Yes, but I'm saying, see, Bristol, that is like we're saying that in future we would use it for different things. We actually deployed this system working for the health staff, the government payroll. So it's ring, but we convince them the way we got the consent, we will not track you beyond 5 p.m. That's a challenge basically, right? After 5 p.m. they don't want anybody to know where they're going or whatever their habits are. It's just that up to 5 p.m. they're willing, they're okay with it. Unless they get the sense of we will actually mean it, where we will not track them beyond 5. But this is again something that requires further considerations from the ethical perspective. Yes.
Is there time?
Yeah, there's 20 minutes. And
Yeah, I was interested in your findings about how you have the BCG vaccine is very high and sort of drops off over time. We found the same thing in Madagascar, study that we were doing, and you said that you had some strategies that you were looking to think about how to maintain, why people aren't coming back to, for the second measles, the second, the third, whatever, vaccines, and how are they all designed to get them in more?
So we are referring to the discussion on the artificial intelligence that we did. So it's just saying why are they not coming back after the BCG? What are the issues? There are risk factors which are known as around 10, 12 of them that we know, that to the low coverage rate or the high dropout rate. There are a lot of patterns that don't know. That's why we're using artificial intelligence, saying, use the routinely collected data and see how much likelihood of it could be explained by the existing variables, and let the system actually identify the patterns. Right? 1 year of deployment, system actually identify new variables, something that is not yet explored, something that we have identified in the global research in space, and things new variables could actually explain part of the reasons why the patterns are not coming, and the system could actually use that in the probability model, saying that okay, at the end of 1 year, the whole point of the system would be 99%. Right now, it is somewhere around 82%.
Paul? First of all, your energy and your is just terrific, and I just want to thank you. I don't know, you keep coming up with these terrific ideas, and I learned a lot. And we also really admire, in this, a lot of the partners. I just want to, and there's a number of visions here, including a physician. There's always a lot of social scientists here. A lot of your friends are social scientists.
Yes.
Among them. So, you were talking about 2011 as ancient history, right? The rapidity of technological change. So I'm embarrassed to say that I did not fully recognize. Like, I know really what geofencing is. Don't say it, Johns Hopkins, okay? But that it's absurd to use 1998. I mean, it's tough to use 1998 census data, right? That's ancient history in demographics. But these approaches, I was just going to say, have been tried before, and I think there is data. There are rather that predates, but you'd have to go outside of the public health and epidemiology literature. For example, a lottery system was used to try and apportion antiretroviral therapy in the early before this is the development of combination chemotherapy, and before, if I'm not mistaken, the AIDS drug assistance program. In our range system, some states didn't even bother applying. Right? They have people with HIV, but much interest in those people. Mississippi, Alabama. I mean, I'm not trying to stigmatize any particular states. I'm saying it doesn't. And again, I'd go to conditional transfers. We may call them that now, but there is obviously a long history of rewarding refractory people for doing what you want them to do in terms of public health. David Jones just gave a brilliant lecture today on Macau and the history of social medicine, right? And none of us are familiar with parts of these these data for engaging about, let's say, health threats that are to be public health, like threats like tuberculosis, I wonder how historical would be, not in terms of your everyday work with groups like maybe even the health service, but certainly a number of these partners who definitely don't seem to be very interested in history, right? And I'm just gonna wind to a question between friends. This point of a lot of these discussions, the ones you've had to have with the Ministry of Health, with Gavi, we all know those discussions. We try to have them as well. But the starting point, just before I say the starting point, you personally and your institution, you have to scramble, bend over. I don't know if they say that in Pakistan, but here, bend over backwards to keep up with both technological change, but also changing fashion, health, ideology, and other things. And a lot, that's a lot for you all. And so, here's the question: when the starting point of discussion is always in a time of limited resources, right? I mean, no matter how much advance you make in Mississippi, Pakistan, go right down, that's always the starting point of interventions. And that is the starting point when to back a little and say, yeah, they're less limited now than ever before in human history, because it's always going to be a pittance for the kind of work that you're doing. You know, there's like 20 cents is too much, or, you know, I mean, this is not a rhetorical question. It's like, how much I'm thinking, of course, of Salman's book, Blind Spot, which seems to be the sea in which you're swimming, just so many of us. You know, it's just not a starter to say that there should be public investments, you know, an adequate level in these worthy things. And I know that's time-specific and site-specific, but what do you think about, is there any possibility for a little bit of pushback there on what is clearly, you know, a neoliberal driving force? After all, we're familiar with how many billions of dollars go into military endeavors in your neighborhood and in this country. There. Sorry.
Yeah, that was a lot.
No, we're
So let me just tell you.
Department of Social Medicine.
So when I'm back, when I finished, I've been working with IIT since 2005. When I moved back to Pakistan in 2003 after finishing my PhD, I had just written with IIT and I took it on. All I had were 3 people. Started with. Now we have around 400 people in the program. So 3 people to 400 people in 3 years span. Basically, just saying the same thing. We have to pass with the technological advancements and other things going on so much. And the whole conception, I don't know if I've seen it in my experience, and some of you would agree that in different countries, I think public health can only be done by doctors and non-relevant people. Like there's not much concept of social scientists and so on. However, basically, we try to get people with the sociology background, the business background, tech background, health system specialists, public health architects, civil engineers. Like it's really a very diverse team.
You know, some of the worst offenders in racing history. Okay.
Could be, but saying bringing all of them together was like saying when we get these things, how to come up with innovative ways to deal with this, doing well, changing well, how to come up with the interventions which are timely. Because one thing is racing against time. When we engage Gavi, when we engage government, saying how to push back. Yes, so there are times when we are like, okay, we have to push back. We're saying like you know, and like again, we keep engaging them. As I said, we start. So it's not we do the pilot and then we say, oh, you know, we got promising this. Let's just go to the government and let's see what they have to say. But we like engage both the national, the provincial, the national, and the international stakeholders from day one. Some yes, we could convince them. Sometimes we don't. So I have other studies, for example, I didn't show where we are able to succeed in convincing them from the day one of the results. The other, we will remember how I push back, especially around the CCTs. It looks like to show them more evidence before they agree to it. That, as I said, like we try to again moving that ecosystem rather than just staying with one person rather than swimming alone, saying okay, yes, eventually something would come. We keep pushing from all these different corners involving different economists, different groups globally, saying that you're doing makes sense. It is promising. How to actually create the momentum.
So when do you think that started? Because the data for unconditional cash transfers is fairly, you know, and before that, conditional cash transfers, and before that, another kind of unconditional cash. When did it start, and how long is it going to last? The first question is fair. The second one is just from your friend.
So think, for example, all these projects started in 80s.
No. Become just not shakeable.
So essentially, for me, if you ask. After I finished this trial, like RCT, I think give me enough, ammunition to fight with these people to push back. If that doesn't get me, essentially, we think the strategy and say how to convince these people to make it work. But this is my final answer. We thought through every variation that one could think around the incentives. As I said, all these different designs, different variations, we put thing into that.
Clearly.
It was like saying that 12-arm study. Almost like 12,000 kids for 3 years, seeing what happens. So that is you're very correct. Even I was not aware about this lottery thing, and a lot of people don't have this evidence, and this is part. But yes, sometimes it's helpful to see what happened, what were the challenges, what failed it, or not, or what succeeded. Like there I didn't show. So after I had to sustain this program after the pilot funding ended, right? And there was 1 year gap in which it was not funded, and these internal resources. Interestingly, these vaccinators who were doing performance-based incentives, we did it in a different mechanism. So rather than lottery, we took out the lottery part of it. So you will still get the money, but the lottery will not be the part of the conditional cash transfer. Even though getting exactly around the $65 average, they weren't really happy about it. They kept coming back to us saying they're getting enough. And maybe it's lottery which is the kicking part. Yeah. Even though you are getting the same amount of money, but your brain, you're like, oh no, all took out the lottery part, and now the motivation.
So you the capacity to earn more.
But the
competition part.
Yes, which kicked in. Now again, things that we will, but those things they're not there. Like people don't know about it. Right? Those there's a thing that what is lottery work? How does it affect your behavior and your thinking process, and what are the results that we want?
I think Paul's point is more, if I may, that isn't about data. You've done a 12-arm study, and somebody may ask you to do a 56-arm study next. But at the end of the day, it may not be about data. It may be about the idea of giving people money.
That is correct. That's what I'm saying. For me, the way, based on discussions so far, the way different stakeholders are being engaged, I think NFM initially engaging them on the idea that this is small and why they should do it, why it makes sense. And right now, World Bank is essentially funding some of the pilot programs in Pakistan and a few other countries. They're supporting conditional cash transfer for immunization. So as I said, we are pushing. It's not like we haven't stopped pushing. But for me personally, saying, okay, when would I stop saying no, maybe I should spend my time into other things rather than keep running after this? Is like saying of the trial, will be solid evidence to convince that this works. And if you don't buy it, for me it's like, okay, let's move on to other things.
I'm concerned about your well-being and sustaining your sustainability, right? Because there's obviously forces declaring a lot of this unsustainable from the get-go. And I just wonder, Salman, when you look at Alma Ata, look at your book about the Bamako initiative. So when we look back from now, we're scrambling to make the package smaller and smaller, and scrambling to make the more conditional and more conditional, scrambling to make it cheaper and cheaper, and calling things like GPS poor man's, what was it again?
Poor man's GPS.
No, the first one? One was poor man's GPS.
The GSM-based
So I'm just saying, I didn't know that, and there are a lot of people who don't know that, but I'm just saying, I'm asking, why will this not be regarded like Gobi? Or
people could question him. Yeah, I think people, when you think of this as a historical, if we move towards a more justice-based delivery system, people may wonder why we're so fixated on doing this for such small amounts. You're trying to do, but that's what the system is pushing people toward, figure out what's the lowest amount that you can do to get people to act a certain way. But the whole, as you know well, the whole field of behavioral economics is playing with these things. Do you do lotteries? Do you give people incentives? Do you take something away from them? Give something and then take it away because they'll behave differently. So there's people that are studying a lot of these
and benefits.
But I think the lessons from South America, from Oportunidades, Bolsa Familia, and I can't remember the name of the one in Nicaragua.
Progression?
Because they basically have shown that if you actually give cash transfers for whatever, it could be for putting children, but you actually bring up a bunch of different health indicators and ranging child development indicators. The Nicaragua one was just remarkable, how kids could do more with their hands and think differently. Just amazing stuff from just cash transfers. So it's interesting.
It is ongoing.
So giving too little, like we give little for this activity, but I think those examples show that bringing families out of poverty has a net beneficial effect. So that's the thing. People that are asking how low can you go, they're not thinking about bringing families out of poverty. They really are thinking the minimal behavioral effect can be elicited from the smallest amount of money.
And it's just got to be difficult. I know it is for me. It's like jumping through those hoops.
We try to show that, to answer these questions in the discussions. We actually went down and said, what do people do with this $2 amount? And actually bought medicine and then the baby supplies like Pampers and those sort of things. Right. So this actually affects. So it's not just about immunizations, but what how this incentive is translated into these other
Well,
things.
I'm talking about what is the traditional and ethical culture of people who are always trying to remember of the flow of resources.
Yeah.
That's you can't do everything, although you seem to be able to, but it's just that's the sea we're swimming in, it seems to be, because you're saying that's out of the question, or that's out of the question, and I believe you, but I'm just wondering what happened, that it was, it happened with partition? No. Is it here now? Yes. How did that, how happened? That's a question, but I don't think it could be answered, without help from.
But one thing that's confusing about this from a broader perspective is the experience of the U.S. always had problems getting vaccination rates up, higher than what you in Pakistan, but not what they should be. And has generally relied on a coercive regimen. If you don't vaccinate your kids, you make your life difficult in various ways. Your kids can't go to camp, kids can't go to school. And then the minute you back on those coercions, vaccination rates fall. So New York and California now start clamping down on the
States that have relaxed.
But in Western Europe, which has done nothing, no cash payments, no coercion, it's purely a voluntary compliance system, they have the highest vaccination rates in the world. And the question is, how to replicate the kind of social capital that exists in Western European countries. But are there other kinds of solutions? Instead of trying to punish people in the U.S. or bribe people elsewhere, are there other mechanisms that could be done to try to achieve the regime that they have in Western Europe?
So one thing, again, even in the Europe, I would say they have some programs, some of the countries have, but again, overall, you're right. Comes down to this is a multi-sectoral approach that needs to be applied here, right? Why people don't come? Again, it's like the education is bad, right? The awareness is so low. And move on these policies again, as I mentioned, the school admission thing, the requirement of the immunization, so on. So if you have to really tackle it on, there needs to be a multi-sectoral approach, happening from the health side, from the social side, from the financial, and the other implications, tax relief, for example, for people who immunize. And like different ways, different approaches. One say that if you have to fix the entire society to not only immunizations, but these other, health problems that we are seeing today. Same in the U.S. Should not work in Pakistan and the developing countries of South Asia, what work in Europe. It's like we're saying, what we're dealing with is simple one problem. The other problems basically feed into it.
Well, synergy of plagues, as David said, is seen here as well, right?
Yeah.
We're not making the claim that it's, there is here. I mean.
But, one of the things, David, that came to mind is Europe has and had a well-developed welfare state with universal education and a variety of things. So I think, we ask what is the variable that fits into it as far as the literacy, the treatment literacy that allows one to want vaccination. It's hard to tease out, but it's probably part of this broader package that lacks in the U.S. and in.
The concern is if you were truly successful at this work, if you got the incentives just right, would that then take the pressure off the government to work on broad health sector reform, better education, and those things? The other ways to get vaccination rates up?
I don't know the answer to that, right? But yes, and then even with what I've seen with the developing countries in South Asia, I would say, with experience in Pakistan and Bangladesh, for they rely on these international stakeholders like, what does World Bank think about it? What does Gavi think about it? What W think about it? Once they need to get on board, and then the government, okay, they're on board now. Okay, so who will actually initially fund so that we could see that broader scale it works, and then essentially we would put our limited money into that basket. So it's not going to be very straightforward. A lot of sales, a lot of challenges, problems, but that's the key in developing countries today.
Probably Singapore air show and buy a plane.
Yeah, it's the reality here, right? I mean,
So you guys see we're out of time, but I want to thank Subhash because our group has been thinking, how do you bring down a number of areas? But one of them is, how do you bring down infant mortality and maternal mortality and a number of other issues? So this is a really important piece in that. So thanks for a fantastic presentation.